back with Dr. Van, everyone, and going through prostate cancer today, which treatment has changed obviously in the last several years. We've talked about it, the diagnosis. We talked about the treatment options and some of the side effects of both radiation and surgery. So now, if you could walk us through, we've made the decision, and walk me through how robotic surgery works, and then how we deal with some of those complications you discussed in the last podcast of urinary incontinence, 5 to 10%, and regrettably erectile dysfunction. I remember at 40%. What you told me, although I tried to forget it, I wasn't able to. So walk me through the surgery and then how we deal with the post-operative complications.
Sure. So with robotic surgery, taking it one step back just to what we used to do, open surgery used to be a big incision from your belly button down to the pubic bone that we would do the operation. And in the 90s, it was refined and became a much more anatomically accurate, if you will, operation. Prior to that, it was really just more of a bloodbath. Now, so in the 90s, they did some anatomic studies, found out exactly how to do this operation the right way, and then come into the around 2000, we started to do robotic surgery, and what that did was cut down on a lot of the complications and all the advantages of any kind of laparoscopic operation. So now, less pain, less blood loss, 4 or 5 little small incisions, out of the hospital the next day, whereas most people used to spend a couple of nights. So those advantages are what robotic surgery did, and made it a much cleaner, more, I would say, anatomically precise operation. And honestly, for us as surgeons, it's not bad either. We do get to sit down at a console. We don't have to really stand over, break our necks, and things like that. So it really is more comfortable from a surgical standpoint too. So there's a lot of advantages of it. Now, what didn't, and I think the continence rates are better than most as far as open surgery priorly. What didn't really change is erectile function rates, and mainly because you're not changing the anatomy, you're just doing the operation a different way. But the robot will allow a patient to convalesce much quicker. I mean, hospital stay, again, overnight. A urinary catheter used to stay in for 2 weeks is out in a week. The operation itself, in the way I do it, takes about an hour and a half that I'm typically working on a patient.
Sure.
A little on the front end and the back end for anesthesia purposes. And about 2 weeks, most people are back to their normal routine, about 2 weeks.
Sure.
Realistically, it takes about a month or so to recover fully. But most people are back to those 2 weeks. Now, once we take that catheter out, the patient's, I can almost guarantee you everybody's going to leak some.
Sure.
Okay, it doesn't happen overnight. But there's exercises called Kegel exercises. We actually have some specialized physical therapists that concentrate in that area, and they will help patients. We even do it before surgery, so they learn how to do these exercises so they can get drier quicker. But everybody's going to leak some. It's variable. If you've got preoperative voiding dysfunction, it may take a little longer, but it will typically resolve.
So urinary incontinence will resolve. So if you could summarize just the surgery itself with the robotics, you preserve the tissue planes.
Right.
Use the term bloodbath, and as a surgeon that scares me.
Right.
But there's less blood loss, less tissue trauma, better visualization and preservation of those anatomical planes, and it's easier on the surgeon. Would there be a situation which you would not recommend a robotic surgery?
Honestly, not many. Now, the only time really is if they've had some type of maybe major abdominal surgery prior to robotic surgery, a major colon resection,
something that would disrupt the anatomy.
Something that would distort the normal anatomy that would make it a little risky to do a laparoscopic procedure.
But pretty much in general,
right.
You're basically going to have to do robotic surgery today.
Correct.
So you get it. We talked about the exercises for incontinence, and do want to spend a little bit of time since it's 40% on erectile dysfunction.
Yeah.
So tell me, a guy comes in, gets his catheter out, 3 weeks later says, yeah, I have a little bit of leakage right at the end, but I'm able to avoid on my own. I'm not in much pain, but I haven't been able to have sexual relations because I can't get an erection. So now they're going to forget what you told them about pre-op about erectile dysfunction. They're going to forget about, oh, my cancer's all out and it's been cut out. So they're saying,
well,
hey.
You're right. Usually that comes up at a later time. They're not concerned. Most men are not terribly concerned about erectile preservation, if you will, when we're doing a cancer talk.
Right.
You know, they just want to make sure you cure it, and they don't want to pee on themselves. Now, some men, some couples, it's not a big deal. That maybe it's an order, and they're just like, hey, that's just not important to us. But most of the time, we're trying to keep it where what you had preoperatively. I'm not going to probably make it any better than it was, but we can, if we can preserve what you have, that's what we do. So the nerves that control the erection run right in a groove right between the rectum and the prostate. And that's a little hard to, without a model, it's hard to picture that anatomically. But let's just put it, they're very, very close to the prostate capsule. And sometimes the cancer is close to the prostate capsule and right close to those nerve bundles. So that's where it becomes tricky with trying to preserve the nerves and also the blood vessels there without getting into the prostate and compromising the cancer portion of the operation. So that's why men get ED, is because of that. And it's not a nerve, I mean, again, talking to a neurosurgeon about nerves, but it's not a nerve that like goes to your leg. This is a nerve that's very, very delicate and an autonomic type nerve, which we can get into that.
Very small, but important nonetheless.
Important stuff, right? So it's easy to damage them. Let's put it that way. So that's why men will get ED. Now we can salvage, about 40–50% of those guys that I was talking about, that 40% with tadalafil or with pills like Viagra or Cialis or something like that.
So that tends to help.
That will help, yes. And if that doesn't, then there's other options. There's a vacuum device. There's injections, which most men like.
A vacuum device is something that creates a negative atmosphere and causes...
And draws blood into the penis.
What's an injection? That sounds scary.
I know, doesn't it?
Yeah.
But, look, the way I explain it is, look, it's a tiny needle like a diabetic's going to use.
And you inject it near the penis?
Into the shaft of the penis. And it's a small amount of medicine. Look,
does that kill the moment?
10 minutes later, 10 minutes later, it's going to feel good. It might hurt for a second, okay?
There's a lot of things in life, I suppose.
But most people, it depends on what's important to you and everything and what is what. But I think most men actually do like that. The nice thing about it, once you inject it, it's coming up. I mean, you can go... you can watch this podcast, or you can watch SportsCenter. It's coming up.
So no, that's an important point. Like you said, it's coming up, and so even if, are there any group of men, or what's the percentage or group of men that would, despite vacuum, Cialis, Viagra, or injections, are still unable to get an erection, or pretty much with the injections? I mean, it's everybody's getting some.
Usually with the injections, most people are getting some. It's just a question of comfortability, because sometimes, without getting into too much pharmacology, sometimes most of the time the injections work fine and people are very happy with them. But sometimes there's a certain medication that sometimes can cause some discomfort, like just some throbbing of the penis, and that can take the pleasure away.
Sure.
So some men don't like that. Some people get tired of just the injection itself and like I just don't like it. So if that happens, then you can move on to something like a penile prosthesis or implant, which
that's pretty rare in today's world, huh?
Yeah, I mean, there's still a good amount that are done, but it's usually for somebody who just won't tolerate anything else, or they're just very sexually active, or that's just decide they just would rather have that device. But it is still done a good bit.
So there's some options. We get beyond the incontinence. We get it beyond the erectile dysfunction.
Right.
Now we're okay. Hey, what's it look like after? I mean, you got all the cancer out. What do I need to do? How long do I need to see you? Can I go live my normal life? Have a beer, have a glass of wine. Is there anything I need to worry about? Down there, should I not exercise? I mean, I'm not talking in the early convalescence period. I'm talking long-term, 6 months out.
No, you'll be able to resume all your normal activities after that. After about 6 weeks, essentially we turn patients loose as far as whatever they want to do in terms of activity. Going back to work, that kind of thing. I will tell people a couple of caveats with that is, if you work where you're doing a lot of strenuous heavy lifting, you might leak a little bit for the first year when you're doing something strenuous. If you drink, that's another thing that freaks people out. If you drink alcohol's a muscle relaxant. You're going to probably leak some. Even if you're dry most of the time, I think you go out and tie one on and you got drunk and then you wet yourself, you're like, I'll get those calls every now and then. Don't panic, it's just alcohol. So those kind of things. But in terms of resuming normal activities, is not a problem and everything, and so you can really go back to normal functional activities. As far as checking, how we surveil cancer,
sure.
About every 3 months for the first year, we'll check a PSA. PSA actually becomes, while it is a screening test, and sometimes, just like getting back to our first podcast, whether or not we should screen at all, now, as a tumor marker, once you have a diagnosis of prostate cancer, PSA becomes very useful, especially in a post-prostatectomy patient.
Because it should be zero, theoretically?
It should be zero, right. So if anything becomes detectable, the number, let me back that up. If the cancer were to ever recur for whatever reason, and people always ask, well, if it's zero or you took the prostate, how's it going to come back? There's always a chance there can be microscopic spread that we just can't detect with imaging or anything, at the time we do the surgery, or do the treatment. So if the if the cancer ever recurs, PSA will typically be the first thing to come up or be detectable, if you will, long before any imaging study would be positive or the patient would feel anything.
So it's important, while it's controversial pre-surgery or pre-prostate cancer, after surgery, then really important to get your PSA and get it in a timely and a routine fashion, because that's the early warning system. Is that correct?
Right.
Okay.
And then, we'd watch it kind of close for the first year. Then we start spacing every 6 months. So, typically every 6 months for about 5 years. And if people are comfortable, go back to once a year. But the important thing is you don't ever stop checking the PSA.
Yeah, so I kind of want to end on that. That's an important distinction. You have prostate cancer, you get treatment, you hear PSA. While there's some controversy on the utility of it before as a screening tool, certainly if you're a guy out there who has a patient out there that has prostate cancer, don't miss your postoperative PSA screening. Really, really important. Take home message.
And if you're a guy on surveillance, don't miss.
Don't miss.
Because if that could be the sign that tells us the cancer is growing.
Great.
PSA, so.
Well, look, even me who follows some of these things and being the medical director, and I've got a much better understanding of prostate cancer today. I hope I never get it. I hope no one ever gets it.
Right.
But thank you for your time today, man. I really appreciate it.
You're quite welcome.
All right.
Enjoyed being here.
Thank you.